Hey guys, it's Rob from the Facebook Myocardial Bridge Support Group. And in this video, I want to show you how to read a CT scan image to spot a myocardial bridge. So as we go through these images, I will point out some of the details using my pointer. You can see on the screen. And I have some arrows on there as well in the PowerPoint, but I'll also use this pointer to point out sort of what I'm talking about. So when you look at a CT image, and just to give you an idea, we're talking about stuff like this, images that look like this. There are certain telltale signs that this is a myocardial bridge that tell you where it is. And some of them are just sort of common sense, and other ones, I learned at Stanford when I asked them a lot of questions out there from Dr. S. And let me go through them real quick. So the signs on a CT that this is a myocardial bridge. So these are the three that I know. There may be other ones that I don't know about. But one of them is that the artery will be abnormally narrowed, okay? Just common sense, because it's getting squashed inside the bridge. So it's going to be narrower in that section. So it's like the tunnel for the garden hose, it goes like this, and then suddenly it's like half that size. And you may wonder, well, how do I know if it's just getting narrower, right, at that point naturally? If the arrows, if the artery is just getting narrow as I go down, and how do I know it's not just a natural narrowing as the artery continues down? And usually, as we'll see in the images that are coming up, you can see that there's a sudden narrowing. So it's abnormally narrow, meaning it's wider, and suddenly it gets very narrow. And also, especially when it gets very narrow and then it widens back out again once it comes out of the myocardial bridge. So it's normal, narrow, and then wide again at the end. So that's one. Okay, so the abnormal narrowing of the artery. And secondly, and this is the big one, this is one I didn't know and Stanford explained to me, is that the artery is actually not supposed to be in the heart, right? Your arteries that feed your heart are not supposed to be in your heart, your main coronary arteries. They're actually supposed to be around your heart and sitting in fat. There's this sort of globulous fat, this yellow stuff that's all around your heart, that your heart sits in fat. And the arteries are supposed to be just like plop sitting in there. And so on the CT image, that fat shows up as black, okay, on the image, shows up as black, okay? The heart itself shows up as like a gray color, okay? And the artery shows up as like a lighter color, okay? So for example, let's take a look at this image right here. You see this black stuff right here when I'm pointing up on the top? Here's the artery, and they're supposed to be black like this, okay? All the way down, they're supposed to be black between, this is the heart, and this is the artery. There's supposed to be black stuff between there. Just like you see at this part down here, the same thing, black between them, a buffer, because really the artery is just hanging out, sitting in all this fat, this black stuff around it in your chest cavity. That's what keeps the arteries from flipping and flopping all over the place, because they're sitting in this fat all around it, okay? But what you see in the bridged area is here, the black disappears. Okay, so here's the black, and then whoops, it's gone right there. That means that what's happened is the artery has dove into the muscle. In other words, the heart muscle is now encasing the artery. It's on the outside of the artery, and it's got a bridge over top of it. Some little layer on this one. It's not very deep on this one, I don't think, but some layer of muscle is on top. Okay, so you no longer see that black. That's the telltale sign. You no longer see the black. It disappears. And then especially when you see it reappear later on down here, that's when you know that middle section is all bridge. Okay, so where the black is gone and you just see artery and then gray muscle, gray heart muscle, then you know that's bridge right there. So that's the second telltale sign. So you have abnormally narrowed and suddenly narrowed arteries, which often then suddenly widen again later. The black buffer of fat between the artery and the heart will disappear and often reappear later. And the artery will go into the gray heart. And then the third thing is that you just see the artery become like kind of choppy looking, smudged, blurry, like someone stepping on it, fuzzy, grainy, that kind of a look to it. Okay. But, or if it's really, really bad and, the thinner part of the artery might even just disappear. It might have been so squashed that you don't even see it anymore. You can see that, for example, artery is nice and clear as it comes down. It's kind of pretty, clear here. But then in the middle, like right about here, it starts to get kind of, the edges of it are not so sharp. It's kind of like wobbly in here. It's not so sharp, right about here. And we'll see more of that later. We'll see some really severe ones that are very blurry. So the general idea is that the myocardial bridges are all a little bit different. Each one's a little bit different than others. So it's some combination of these three things, of the abnormal or sudden narrowing, the black area disappearing. You see that for sure. And then the smudginess, the blurriness, the choppiness, or the disappearance. Some combination of those together. If you see them all, it's a very good chance it's a myocardial bridge. Now, just so we know, we're not saying here that we can measure the specific length of a myocardial bridge right here, just looking at it like this, because it's difficult to know exactly where it actually goes into the heart and exactly where it comes out. It's easier said than done, but they can get usually a pretty decent estimate. For example, in my case, the estimate was not too far different from what it actually was during surgery. I think it was like 2.7 something estimate, 2.5 something surgery. But having said that, some really good hospitals, including all of the famous ones, have, for myocardial bridges, have often underestimated, I won't say often all the time, but in several cases, underestimated the length of myocardial bridges. So it's not an exact science. It's nobody to blame. It's just a difficult thing to do. But that's to say that I'm not making this video so we can measure them ourselves. That's not why I'm making this. We just want to know if it's there or not. And then secondly, before we look at these, it's not possible, according to Stanford, to measure the depth from a CT, not even to estimate. You don't know. You can't really know an accurate depth. You can see if it's super deep. If it's, you could see, okay, that's really, really deep. But it's hard to get an actual, number of centimeters or millimeters or something like that from a CT. But as we're about to look at these examples, I have a lot of examples in this video, the three sections of the artery. The top part of the artery is called the proximal part. The middle of the artery is called the mid, like mid LAD, for example. And then distal is the bottom part of the artery. So there's specific points where these things start and end, like where certain branches come off, but we'll just say the top part's the proximal, the mid, and the distal. So if they tell you have a distal or a mid to distal myocardial bridge, that means it starts in the middle and then goes down to the bottom of the artery. So this one it's pretty long. You can see, we don't know the exact length, but you can see, it starts high up in the proximal area up here and goes all the way down well into the mid area. And you can see all the things that we talked about. It's narrowed. How do we know it's narrowed? Because look, it comes down like this and it gets right in here. It gets really narrow and then it actually gets wider later. Okay, that's a telltale sign if it's wider after the bridge, right? If it's wider down here than it is in the bridge, it should be the opposite, right? As the artery goes down, it should be wider at the bottom, at the top and the bottom. But here you see this part is actually narrower than what comes after. That tells you it's getting squashed, right? So that, and then it's blurry in here. It's fuzzy. That's the second thing. And then, like we said, the super telltale sign, the black just totally disappeared. The black fat that's supposed to be around the artery, it's just gone through this whole section right in here. So all three of the above, all three things are present. All the telltale signs are present in this one. Here's another one. This one shows more of the narrowing than the one we just saw. So this one comes down nice and fat, or what they call patent. If they write patent on your PATENT on your report, that's just another way of saying wide open. It's open artery. It's wide. This one starts out patent, but then looks like somebody's shoe is stepping on the garden hose right here, right? So it's like really squashed. So that's one where you can see the abnormal narrowing loud and clear. It's right there. And then, like we said, at the bottom here, not only does it get narrowed suddenly, but then it gets opened up suddenly too. It gets unnarrowed, right? It gets widened suddenly as well, which tells you that it wasn't just kind of like an artery that was naturally narrow at the end, because if it wasn't, why would it become wider again? And then it's also nice and light, and then it becomes sort of blurry in the middle here, darker and fuzzy. And then the third telltale sign, the black stuff, the black fat stuff, disappears right in here. Okay, so right about there, it seems to sort of end when the black fat comes back, and then right there. So that black fat is basically telling you that there's something in between the artery and the heart. And if there's something in between the artery and the heart, then the artery can't be in the heart. So it can't be the bridge. This can't be a bridge section if there's fat sitting there between the two. Okay, so that one's a pretty pronounced myocardial bridge, but it doesn't look particularly deep. And I'll tell you why in just a second. There's something else we haven't talked about yet, which is this. So this one is a little bit shallower, it looks like, than this one, because this one here is shorter. But notice that here's your heart, the gray stuff, and then here's the black stuff. Okay, and it ends right there, and then the black fat ends right there, then it goes gray. Okay, and it's abnormally narrow, it's fuzzy. So we get all three elements: the fuzzy blurriness, the narrowness, and then the black fat disappearing. But there's this other thing which tells us it's probably on the deeper side, and that's that. Notice that where the arrow's pointing. See this? This is the heart up here. In other words, there's a big, thick band of muscle up here beyond the artery on the other side, like outside the artery. Whereas here in the previous one, we didn't really see that too much, right? There's not really a lot of gray on the outside of the artery, just on the inside where the heart is. That tells you it's probably a little more superficial, but that doesn't mean it can't cause symptoms. It's even, as Dr. Boyd said at Stanford, even a super thin band of muscle can wreak havoc. It's his words to me face to face. So this one is not super thin. It's, you can see the muscle is substantial. But that gray stuff is heart muscle on the outside of the artery. And so this one's deeper. And you can kind of get that sense too, because this one also doesn't bend hard, right? Doesn't bend hard into the muscle, the heart muscle, but this one kind of does, right? It kind of dips down further, meaning it's really being it's taking a detour into the muscle, so it's deeper. Now they can get even deeper than that, as we're about to see. So here's one. You know, we've got some people on our site who had super deep and super long bridges, and you know, here we're talking about it starts basically in the proximal area, the top part of the artery right here, right off the bat. Artery barely even starts before it goes into the heart muscle right here. And you can see it's deep. Why do we know it's deep? Because the gray heart muscle is on the outside of it, and there's a lot of heart muscle out here. So all this gray stuff. So that's all over top of the artery out here, this part, where it's all these white things are pointing. So all that's the heart muscle outside. That means that that's a thickness of muscle that the artery is below, right? It's below all that. It's like in a sandwich in there. So that's pretty deep. It could be deeper, but that's pretty deep, you know. And so it keeps going like that all the way down like this. Here's another example of a relatively long and deep bridge. Here you have the telltale signs. The artery is squashed. It's sort of faded in the middle, and also you get this huge amount of muscle on the outside, which is all squashing down on it. And the black fat here disappears quickly. It only there for a little bit, and then it comes back in again way down here. That means that all of this, it says almost 3.5 centimeters, 34.3 millimeters is bridge. It's all myocardial bridge. So basically, this one is on the longer side. Usually, they say 2 centimeters is kind of a rule of thumb at Stanford for minimum cutoff for surgery. But I don't think there should be any cutoff for surgery. It's, you know, for in terms of length, really, it's just, you know, what if it's half a centimeter, but it's crushing the artery? Like, who cares? It's, you know, it's the effect that matters, not the length, because they can be very, very deep and short, as we're about to see as well. Okay, so that's a relatively long one. They can be even longer than that. You know, we've had people on our site who basically their myocardial bridges were so long that the doctors, they used a surgical ruler, it's like I think it's a metal ruler, that it couldn't measure it. That's how long it was. Like the ruler's like 10 centimeters or whatever, and it was past that. So in other words, their entire artery was in the heart and deep. So so yeah, so 3.5 millimeters approximately here is on the longer side, but it can be even longer to where it's the entire artery. So we've seen some longer ones, but here's a shorter one, but it's kind of nasty. If you see, here it comes down, there's some black stuff, but then the black stuff goes out and then it becomes real narrow real quick. So it's nice and patent, nice and wide here, and then it gets real narrow just suddenly, like that shoe just stepped on it. And all this stuff out here, you know, this heart muscle is on top of it, squashing it. So it's going diving deep into the muscle right there. That's not good. That's not good. And that's kind of the point I was trying to make earlier. Like, if it can be short, and some people sometimes it can be 1 centimeter, 1.5 centimeters, and but if it's sharp like that, see that angle is very steep. It's a very sharp angle. That's getting crushed hard every heartbeat and can cause a lot of pain, a lot of shortness of breath, all the kinds of symptoms that everybody has, faintness, all these things. It's very acute, you know, because it's very specific to that location right there. So you can just kind of see that, how that could be really problematic. That steep, short myocardial bridge, but still very much squeezed by the heart because there's so much heart muscle bridging it on top of it, squeezing down on it every time. Now, we said like these can be very steep. This is like very steep right here. So here comes the artery, and whoa, it takes a huge turn into the muscle. And if you have a super sharp turn, it kind of causes a problem around the corner. They call that a kink, like a very hard turn where just the turn itself can make that corner where it turns narrow even more and cut off circulation even more. They call it a kink in your artery. So you can see how it's kind of faded out right there. That means blood's not getting through there very well at that corner. So it's not only a myocardial bridge, but it's got that kink in it at that corner, and that's causing problems too. So it's real deep, and it's got the kink, and it's pretty long too, because you can see it goes in. There's no black stuff between it and the heart at all, and then it doesn't come up for air, so to speak. It doesn't come out of the water. Right? It doesn't come out of the heart until way down here at the bottom where the black stuff goes back. So it's a long bridge, but this section of it right here is particularly nasty, you know. So, you know, there was, just for perspective, there was a study in China where a guy had a 1 centimeter myocardial bridge. I think it wasn't even on his LAD, it was on his right side. And he caused him crushing chest pain, and he collapsed just from a 1 centimeter myocardial bridge. And so some doctors will deny that that's possible, you know, that sort of a bridge could possibly cause symptoms, or that any bridges could cause symptoms. And all you need to do is look at this picture, and you can see how that's possible, right? If something can be very short like this, but if it's diving almost, you know, very steeply into the heart muscle, and it's getting squeezed and twisted like that every single heartbeat, it's basically like you're blocking the artery, you know, every heartbeat. So obviously that's going to cause problems. This is so we've seen a lot of their proximal and mid so far. We've seen the upper part of the artery, then the mid. This one is mid to distal, so middle to the end, and just happens to be my own. It's if you see my name down here upside down, Thornette. So I turned it upside down because they had it. I got this in China, and they had it the other way. But so here it comes here, and there's some black stuff in between here. But it goes out, and then you can see the arteries. In other words, the width of the artery stays pretty consistent down like this until the garden hose getting stepped on right here, right? It just becomes real narrow, real quick. We talked about smudged and faded and blurry and grainy and choppy and all that, basically all the way down. So I'm not even sure. I haven't had a CT scan since. I'd like to, since my operation. This is before the operation. I'd like to see, but you could see, and it's another good point. People wonder sometimes, well, why do you still have symptoms after your surgery? And we have another video we made about that myth that somehow, if you still have symptoms after surgery, that means the surgery didn't work. The surgery's point is to take the myocardial bridge away, to take the band of muscle off the artery. The surgery is not supposed to heal the artery. It's supposed to remove a piece of muscle off of the artery. So there's two separate things. And just a little side note, there's something, if you have symptoms after surgery, there's something I've been doing. It's called EECP treatment, EECP. It stands for electro something counter pulsation. You look it up online. There's a great video. It's called Straight from the Heart, EECP, counter pulsation. And basically, it pushes this blood up into your upper body for 1 hour, 35 times, 35 hours, and it really stimulates the arteries to grow and new arteries to grow. It's amazing. So it's been helping me a lot. If you have symptoms after your surgery, definitely check out EECP therapy. It's not even that expensive. And I'll probably make another video about that later. But here's another angle on it. This is, we can now look at some 3D images, and they come in different sort of shapes and sizes. The three-dimensional models that they make from your CT scan. This is the one that I got from China, and you can see, for example, the LCX artery comes down nice and patent, the RCA, the diagonal, and then here's the LAD coming down. It looks good, and then that last part that we just saw is all like mashed there. So that's very visible when they isolate the artery in the three-dimensional model. But a lot of times you get this type of three-dimensional model. This is different, somebody else, and you can see, okay, here comes the LAD, and it just drops out right there. So that's a proximal myocardial bridge. Upper part of the artery has it not too long, but it looks pretty deep. And we can say that because we don't know how deep, but we can say it looks pretty deep because you don't see it at all. So in that section right there, you don't see even a trace of the artery. And that tells you it's probably pretty deep because you don't even, if it was superficial, it would only be a very thin band of muscle on top, and you'd still see the relief or the elevation extruded of the artery, but you see nothing here. You just see nothing. You see the surface of the heart. So whatever your myocardial bridge is, whether yours is mid, you'll see this artery will kind of disappear in here, or fade out in there, or at the bottom, or just wherever yours might be. You just want to look for that. And just a side note, I want to be clear that the LAD, the left anterior descending artery, is not the only place where you can have a myocardial bridge. We're just using that here as an example because that's typically where they find them, because that's typically where they look for them. But there are lots of places you can find on any artery you can have a myocardial bridge. The LAD is the most important artery because it's the one that feeds the left ventricle, which is the part of the chamber of the heart or the fore that pumps the blood out, goes out to the body from there. So that's real important. The other ones are important too, but they're not as important as that one. So that's what they focus on. But the other ones are very important. And you should have, if you have multiple myocardial bridges, or there's one on your right corner artery or whatever, get that unroofed. Don't let them tell you, don't worry about that other one. No, get them all unroofed for sure. So here's one last one. It's another three-dimensional model. And this one again starts relatively high, but this one, before we saw it dive into the muscle and come right back up again, kind of a scuba diver diving in there, coming right back out again. This one here, though, it dives in, and then it's pretty much just kind of cruising underneath for the whole way down. So this bridge is very long, it looks like. We don't see the artery really pop out completely ever, and like we should be like this. We should see it very loud and clear, like these other ones, like the diagonal and the branches and stuff like that. But we do actually see traces of it, though. So we can trace it down like this. So maybe it's a little more superficial than say this one right here. but it also looks much longer than that one right there. So it's more, maybe superficial, but also longer, something like that. So that's a look at how to spot your myocardial bridge on a CT image. They're all a little bit different. So, you know, you want to apply these ideas generally as you find them on your CT. It can be tricky. It can be tricky because sometimes, you know, you're not sure, is it going in? Is it not? Is it narrowing? Is it not? But one of the keys is when you're not sure is to look for the combination of all three of these things. Do you see the narrowing and then the widening later, for example? Do you see the black area disappearing between the artery and the heart? And do you see it smudged, blurry, choppy, or even disappear? If you see two or three of those, you know, and they're very pronounced and you can definitely see them, there's a good chance it's a myocardial bridge. They can be sometimes deceiving, but if you see all of them and they're all there, then it's a very good chance that what you're seeing is your myocardial bridge. Now that we've been through this, you can see that it's not rocket science. You know, this is not something you need to go to medical school just to see these three things, you know, but at the same time, it's amazing that many doctors do not know these things that we just said. They don't know that. They don't know this. And I know this from my own personal experience. I had a doctor who was listed as one of the top doctors at one of the top heart centers in the United States, as a top place in Philadelphia for heart issues. And he looked at the same CT scan that I just showed you that you could easily see where I was talking about. And he said to me, Robert, I'm sorry, but I don't know how to read these for myocardial bridges. And he didn't bother to, you know, like look it up on the internet or anything like that. So, and I had another surgeon tell me that I didn't have a myocardial bridge, even when he was holding the CT that you just saw in his hand. So even though it's not that complicated, I mean, it's, you know, it can be tricky, but the basics are there. We should realize that not everybody in a lab coat knows how to do this just because they went to medical school, because a lot of times the coverage of myocardial bridges in medical school is like, you know, 5 minutes, 10 minutes in a lecture, in a paragraph in a book, and that's it. We you know, we don't want to get the illusion that medical school was a 20-year experience. It's a couple of years in school to study every possible issue they can think of. So they didn't give a lot of treatment to myocardial bridges often in medical school, and many people went to medical school a long time ago. And secondly, not all cardiologists or even surgeons are trained in radiology, which is reading the scans for things like myocardial bridges. So they often rely on the radiologist to do what we just said, to know these techniques of how to find the myocardial bridges. So basically, sometimes you have to be your own doctor. If you think your doctor may have missed it, or if one said you had a myocardial bridge and one didn't, okay, well then now you can check yourself and you can see, okay, do I have one or not? Usually the experience on our site is that if somebody said you had a myocardial bridge, 9 times out of 10, you do. Once in a blue moon, I think I can count 1, maybe 2 people who turned out not to have one. But almost everyone who somebody found a myocardial bridge on their scan, some radiologist at one hospital, even if some other one later said they did and it turned out that they did. It's usually the case. I won't say always, but usually. So hopefully this video will help you verify that for yourself. Good luck.